The ACTION trial addresses the use of heparin in non-cardiac arterial interventions, and we have been using heparin for ages purely to avoid thromboembolic complications. But the dose we used was 5,000 units as a single bolus. And in cardiac interventions, it was proven long ago that you should measure the effect because heparin has a non-predictable effect in individual patients. And slowly we started to realize that we could be low with the dose of heparin. So we started measuring the effect of heparin by measuring the ACT. And it appeared that the bolus of 5,000 units, which we have been using for decades, does not supply the patient with adequate and safe anticoagulation. So we decided to create a new protocol in which we start with 100 units per kilogram and then do additional doses based on the actual ACT. And then we find in a short pilot that the thromboembolic complications were halved. So for all procedures, they went down from 11 to 6%, and for open AAA surgery, it went down from 22 to 7%. So that's a major advantage in patient care and safety. That's why we decided, after this pilot results, to start a huge trial, large trial, with open AAA surgery. We did a pilot study, which was non-randomized, in 4 large vascular centers in the Netherlands. And then we just compared the results from the 5,000 units group with the new protocol. And after these positive results from this pilot, we designed a state-of-the-art randomized controlled trial in which 2 groups will be included, one with 5,000 units and one with ACT-guided heparinisation. So it will be, after the pilot, a state-of-the-art randomized controlled trial. What we found in the pilot study is that there is a huge decrease in thromboembolic complications, which was even surprising for us because it was more than we expected. The difference for open AAA surgery from 22 to 7% of thromboembolic complications was a large difference, but it was not statistically significant. And that's why the pilot gave us and the Dutch government all the ammunition we needed to fund the large trial. We will include in 5 years 750 patients during open AAA surgery in Europe to obtain a difference of combined endpoint of thromboembolic complications and mortality from 19 to 11%. And that's a huge difference. We will be doing interim analysis, but that's the goal. So that's the data we're hoping to present, an interim analysis after 2 years and in 4 years the final results.